Hello, everybody, and welcome to this RPTH Research Recap, where we dive a little deeper into the science published by RPTH. Today's recap is supported by Takeda Pharmaceuticals U.S.A. through an educational grant. I'm Mike Makris. I'm the Editor-in-Chief of Research and Practice in Thrombosis and Hemostasis. I'm a clinical academic hematologist in the UK. Today we have two speakers with us. It's the first time our research recaps have two speakers, but you'll understand why. Our first speaker is Robert Sidonio, who is the director of the Hemostasis and Thrombosis Clinical Operations at the Children's Healthcare of Atlanta and Emory University. He trained at the University of Alabama, University of Louisville, and University of Pittsburgh. His research interests, I'm sure, are well known to you in hemophilia with and without inhibitors, in women and girls with bleeding disorders, in von Willebrand's disease. And Dr. Sidonio, he recently published a paper in RPTH, which will be the main area of discussion today. And the title of that paper, as you all are aware, since you joined us, is Activate Prothrombin Complex Concentrate in Patients Receiving Emicizumab Prophylaxis from Evidence to Clinical Practice. And we also have today Cedric Hermans, who published a commentary on this paper in the same issue of RPTH. And Cedric is the head of the Division of Hematology, head of Hemostasis and Thrombosis, and of the Hemophilia Center at the St. Luke University Hospital in Brussels. He is the editor of the journal Hemophilia, and his research interests are in all areas of hemostasis and thrombosis. And importantly, as well as managing hemophilia, he also works in the areas of anticoagulation and management of thrombosis, which is an important area for today. And Cedric published the commentary, hence why we are going to ask him to comment after Robert's presentation. For those who are joining us live, please feel free to share your comments and questions in the chat. We'll address them during the discussion portion at the end of this webinar. We'll begin today by hearing from Dr. Sidonio, who will give his presentation. So over to you, Robert.
Yes, yeah, thank you. Pull up the slides here. Give me 1 second. So hopefully it's in the correct view. And so first of all, thank you to RPTH. Thank you for this educational initiative. And, I also, and thank you, Mike and Cedric, for being on here to discuss this important topic. So I'm going to talk a little bit about this paper. And the rationale behind this was that, when we talk about hemophilia, we need to look at it from a world perspective. And it's important to understand that just because your situation at your institution where you easily have access to recombinant 7A, that does not mean that's the same scenario in other countries. And so it's important that we have multiple options for treatment. And that was sort of the premise for doing this review. And I also want to thank the authors that were obviously very involved in this publication. These are my disclosures. So I don't have to tell this audience, many of you remember the PHENOX study, and the most important thing that came out of that study was that there was a discordant response to either factor 7A or APCCs or FIBA. And that was an issue in the pre-emicizumab era. And then emicizumab came along, and then we were sort of forced to deal with only utilizing one option, and we'll talk about that in a little bit. But since then, there have been heterogeneous responses to the different classes of bypassing agents here when patient is on prophylaxis with emicizumab. The first one is from one of my colleagues here, Dr. Karen Zamowski, reporting on a case, 2 trauma-induced bleeds in a young children and an older patient with spontaneous mesenteric hematoma. And then you can see Dr. Batsuli, also at our institution now at Stanford, reported on a case in which there was a spontaneous iliopsoas hematoma that did not respond to 7A and subsequently responded to a reduced dose of APCCs listed there. So I think it's important that we, make sure that we have the proper drugs and we have options for our patients, because as you take care of any hemophilia patients, you learn over time, they don't all respond exactly the same. And oftentimes you have to be creative and come up with other options to achieve hemostasis. So just briefly, if you look back at the guidelines in 2013 from WFH, the management of bleeding, acute bleeding in those with inhibitors, and this is in the pre-emicizumab era, of course, was that you could use either APCCs or recombinant 7A. There were different dosing regimens, and there was even sequential dosing strategies that were available. Fast forward to 2020, the decision was made based on the black box warning that recombinant 7A should be the preferred bypassing agent to be used. And if the dose of APCC is used, it should not exceed a single dose of 50 units per kilo, and then not a 24-hour dose of 100 units per kilo. And then as new data sort of accumulated, we sort of modified and sort of softened our approach that APCCs could be used. This also showed up in our MASAC guidelines, but again, the same warning of less than 100 units per kilo in a 24-hour period, which usually isn't an issue because most patients respond fairly well to 1 or 2 doses. And there are a couple of scenarios that we'll talk about. So a lot of the data that we have came initially from the Haven clinical trial series. And so as part of this paper, what we wanted to do is provide a narrative review. We thought there's been a lot published. It would be really nice to have one publication that would summarize all of this detail. And so our goal was pretty simple. It was to evaluate the available evidence on the use of APCC in persons with Hem A inhibitors that are on emicizumab prophylaxis, and then discuss the implications of this data, these data for clinical management. So we took the Haven clinical trial series. As you remember, this was the emicizumab prophylaxis study series. And you can see Haven 1 was for adults with inhibitors. Haven 2 was children with inhibitors. We didn't include Haven 3 because it was non-inhibitors. And we included only those patients from Haven 4 that had inhibitors. What was really interesting is if you look at the predominance of the bleeding events, they were joint bleeds, although the number of bleeds obviously was significantly reduced when they're on emicizumab prophylaxis. And interesting enough, the untreated bleeds, they were predominantly also musculoskeletal and joint bleeds as well. So additional data on real world evidence, and this is one of those things that if you take care of a hemophilia patient, there's a few things in this world that are constant. Hemophilia patients will bleed, and maybe in the future this is not true, but there always will be scenarios in which a patient will be presented in a situation in which they have a concern for bleeding, and it's not always hemophilia related. It could be related to trauma. And so we know that patients will continue to bleed. They will need bypassing agent drugs to mitigate that bleeding. And so I think it's important that we have every available strategy to us as we take care of these patients. If you take the Haven clinical trial series, you can see here there were 130 bleeds and 37 patients that were treated with APCCs. 81% of those bleeds were treated in less than 24-hour periods, and most of those were a single dose. No thrombotic microangiopathic events were seen in that period. This aligns with the data that most patients can be treated with 1 to 2 doses of APCC. If you look now, 76 or 99 out of those 130 bleeds were treated with less than 100 units per kilo of APCC. And you can see that's 24 to 48 and 48 hours. And again, no TMA events were observed. And most of those were treated with around 50 to 100 units per kilo a day. So they were sort of toeing the line of what was considered, concerning. And again, remember, this was a trial that was going on, and there were no sort of guardrails on what dosing to use for APCCs for acute bleeding events. So this is where you started to see the events. So 24% of the bleeds, or 31 of those bleeds, were treated with over 100 units per kilo in a day. And you can see 21 of them were less than 48 hours, and then 10 of them were in the 48-hour periods. And TMAs only occurred if the dosing was done over 100 units per kilo a day for greater than 48 hours. And it's important that we distinguish that, because we have, a very good wide window of protection in our guidance. Two out of three of those events, patients were on emicizumab and had received 7A first, and then APCCs, or had received them sort of in a sequential pattern. And so it's important when you look at, obviously we're focusing on the safety issues, but it's important to understand that there were a lot of patients that were treated on the study for surgeries, for bleeds. 96% of them were treated successfully without TMAs or thrombotic events. And so at the time, obviously, these were frightening events. They happened very quickly. And so there was a lot of concerns. And so we put in really strict guardrails, which is important in this community. But I think we always need to go back to the context of this. And I remember at the time there was discussion about removing FIBA from people's homes. And so, I think the decisions made at the time were correct. But over time, as you accumulate more data, we need to modify those decision making. And so you can see here, this is a summary of one of the tables of the series that are happening over time. You can see the Stacy clinical trial series. There are 13 bleeds and 5 events, no TMAs or thrombotic events. The ones I mentioned here with Zamowski and Batsuli, again, no TMAs or thrombotic events. And then Yassim Dargod published one of the first post-approval case series or case report in which there was a bleed in a patient with a perirenal hematoma, and she gave 25 units per kilo of FIBA, and you can see the dosing regimen there was very careful. And again, no TMA or thrombotic events. You can see here there was one TMA reported in a diverticular hemorrhage. You can see the doses there. This was, again, a combination dosing, and they were using higher doses than was recommended. And again, if you look at the surgery series in the Stacy trial, we didn't see any TMA events. And this was an interesting patient as well. This was a major orthopedic procedure in which they did not hold emicizumab, in which there were enough half-lives held, and they gave full dosing, or at least full pre-emicizumab dosing for management. And not surprisingly, the patient developed a TMA. This is an event that happened in the Midwest in the United States. So we've talked about emicizumab prophylaxis and the mitigation of these events. We know that there are other drugs that have been approved, and since the paper has been published, they've been approved. And so if you look at this, and many people were not aware that you could use APCCs in the Concizumab or Explorer 7 series, and you can see here the mean dose, or the median dose, is about 50 units per kilo. And you can see most of the patients were getting 1 or 2 infusions. This is a 45 bleeds, and there were no TMA or thrombotic events reported. In the Atlas series, which is the one for fitusiran, there are a number of series that they have. But if you look at all those, and the 2 patients in the initial one, there were no TMAs or thrombotic events. And again, 6 bleeds in 3 patients. And again, there were no TMA or thrombotic events reported. And so I think with careful utilization of APCCs, we can avoid these events. And at our institution, we have patients that respond better to FIBA, and we utilize that sometimes upfront, because we don't want that delay in treatment, particularly for the patients that come in delayed in their response. So you can see here, as evidenced by the arrows, at least early on, we are not seeing this with the other non-factor therapies, or the TFPI therapies, or the small interfering RNA therapies. So to summarize, I think it's important that we have both classes of bypassing agents. Again, I think even though we have really good drugs that mitigate the bleeding, we still need to continue with our approach, which is individualization of treatment, what works best for the patients. And we had some patients that were a little hesitant to go initially on emicizumab because they had such a good response to FIBA in the past that they were worried that we were going to restrict their use afterwards. And And obviously, we've modified our approach after a few years of observation and a couple of our own cases. So since the guidelines were published recommending the use of 7A over APCC, obviously more data has become available. Evidence from clinical trials and real-world studies demonstrate that FIBA has been used without thrombotic complications at a dose of less than 100 units per kilo per day in patients receiving emicizumab prophylaxis. And in the era of emicizumab non-factor therapies, obviously we need to have good bleed management. We need to have both classes of drugs available. We know that both classes of drugs are not widely available throughout the world. And we need to have this data available for our colleagues in case they're in a situation in which they need to use APCCs. And so obviously sharing the data and individual experiences, I know people often write these case series up. They wonder how useful they are. Well, they're very useful for people like me trying to summarize this data because I think it really helps the community. So please continue to publish those case series. Those phase 4 registries are very important. So thank you very much. And again, I want to thank the authors of the publication and Takeda for their assistance in putting the paper together. Thank you.
Thank you, Robert, for that excellent and very clear presentation. As I mentioned already, if you want to ask a question to either Robert or Cedric, please add them in the comments. So far, we only got one comment, one question. So when the Robert's paper was published in RPTH a few months ago, Cedric Hermans wrote a commentary, and in view of that, we felt it would be useful to get Cedric's opinion about the subject and give us his thoughts about this issue. Cedric, over to you.
Yeah, thank you, Mar. Thank you, Robert. So thank you for allowing me to share these comments, this commentary. So maybe next slide. Yeah, so this is, well, the title was, I think, very gentle, highlighting, really the importance of the work that Robert just shared with you. Clearly, there is new evidence and clinical consideration that already know, but in the future will certainly impact on our practice. Next. And to make this clearer to those of you who might be a little bit less experienced with the importance of this kind of work, I'd like to summarize again, what these inhibitors are doing. So, many young patients with hemophilia, at least if they are treated with factor VIII, are at risk of developing alloantibodies. And because of this, they will present with bleeding episodes that require either, or together bypassing agent given ideally prophylactically, but that used to be quite complicated, or on demand, and ideally also eradication of this inhibitor by ITI, which is associated with huge burden and huge cost. But we know that the recent introduction of emicizumab and its validation has completely changed the way we treat patients with inhibitors. Next slide. And I think this is important to consider what these agents are doing. Currently, we have 3 bypassing agents for patients with inhibitors. We have emicizumab that is given prophylactically, and we have the 2 older agents, 7A, that can be given on demand prophylactically also, but much more complicated, and FIBA APCC on demand also can be given prophylactically much more easily than 7A. Next. And just to put this a little bit visually, it's really fascinating to think about this. These patients do develop an alloantibodies against factor VIII. It could be an autoantibody in case of acquired hemophilia. And here the strategy that has been validated is to use a bispecific antibody to allow our patient to clot. So it's not only, emicizumab is not only a mimicking agent, it's also a bypassing agent that has completely changed the management of patients with and without inhibitors. Next. But I think this is an important concept, although many patients are currently on emicizumab globally, and clearly there is a major enthusiasm for that treatment. I think emicizumab has important limitation. It's not a monotherapy for several reasons. First of all, it has a delayed onset of action, as you know, and also emicizumab does not complete correct coagulation. So that means that patients are still at risk of breakthrough bleeds, and patients certainly need adjunctive hemostatic therapy if they present with breakthrough bleeds or undergo invasive procedure. And as you know, for patients who have been on emicizumab for a long period of time, maybe their factor VIII inhibitors is not longer detectable, and these patients could potentially treat it with factor VIII again, although the inhibitor will likely come back. If the patient do still have an inhibitor, they will need bypassing agents, 7A or APCC. Because these two agents have clear advantages. They have a rapid onset of action, and they are also titrable. Next. And well, you all know the mode of action of emicizumab. I sometimes compare it to the tinder of coagulation, binding on one side to 9A and allowing the conversion of 10 into 10A. Next. It's clear that when you treat patients with emicizumab jointly with APCC, that means that you give this bispecific antibody plenty of factor 9, plenty of factor 10 to bind to. And so this is what we find in FIBA. And in FIBA, as you know, factor 9 and 10 are in active form. And clearly, because of this, these patients will develop thrombosis. Yeah, next. So there have been several safety concerns, and Robert just went through them. So the finding that some patients did present with thrombotic events, and also very dramatic events, this thrombotic microangiopathy that were described back in 2017 on patients receiving AMI and APCC. And because of this, there was a major fear of combining these two treatments. Clearly, there is an excess thrombin generation if this patient receives FIBA, certainly for prolonged periods. And the guidelines had to clearly state that it would not be recommended to combine APCC in patients treated with emicizumab, and that had major implication. Next. And clearly, the work that Robert just shared with you is important. So it's a compilation of all the case of that could be collected in the literature of patients receiving APCC with EMI. And Robert just shared with you that, yes, there have been some thrombotic events, but they all were observed in patients who were treated with high dose for a prolonged period. So I think this is a very important finding that should impact on the way we treat our patients. Next. So because of this, I think clearly our practice should certainly be modified, and it's not unlikely that APCC should be reintroduced cautiously in patients treated with emicizumab, but with great caution, as Robert just said, not exceeding more than 100 units per kilogram per day, avoid combination, and also with a very strict, close clinical and laboratory monitoring if available. And it's likely that 7A remains the first option. But we know that 7A has several limitations in this context. Next slide. And I would like, although this is a great work, but that was also the purpose of this commentary, to highlight some of the limitations. The first one is clearly the narrative nature of this work, which is not a systematic review with a relatively small sample size. So this is important to highlight. Also, in my commentary, I emphasize the fact that mainly clinical trials data were included, which much less data, real-life data. So this is important to emphasize. And clearly, when you collect that kind of data, if you analyze this kind of data, even in a very rigorous way, there is always a risk of underreporting adverse events. Also, this data were analyzed more or less collectively, so it's quite difficult to have I would say, a granular individual analysis of the patients who developed a thrombosis, and also of the patients who did not develop a thrombosis. Because, it would have been nice to perform some sort of complex statistical analysis to really identify what were the risk factors. Well, clearly the risk factors are the combination of AMI and FIBA at high dose for prolonged period, but maybe, to what extent individual variables could have influenced that risk or could have protected the patient, that was not possible to analyze. And then also, well, there were relatively few thrombotic events, so this is great news for the patients, but that had a negative impact on the statistical power of this analysis. And also, I would like to emphasize that most of the episodes of co-treatment that could be analyzed were in fact in patients who received these combinations for breakthrough bleeds. As far as I remember, there were a few cases of perioperative use of APCs plus FIBA, and we know that this is a clear indication for co-treatment. Also, as you know, this is a quickly evolving field with new mimetics currently being developed who could be more potent with more affinity, binding affinity to 9A and 10. So it's not clear to what extent this observation could be applied to these future agents. They are not yet available, but they will be available in the future. And let's also not forget that although this is not, well, AMI has not been officially registered for that use, it's widely used for patients with acquired hemophilia. And also, I don't think that at this stage we can extrapolate all these findings to patients with acquired hemophilia, or if we do it, we should do this with great caution. Next. What are the clinical implications? Well, I think this data could support or should support a cautious reintroduction of APCC, but under very strict condition. I think it's quite important today, but Robert already emphasized this, to inform the patient about, what is the current status of knowledge, what we know about this, because it's clear that over the last few years, the reputation of combining these two agents has been severely damaged. I think it's also very important to make sure that experienced clinicians do oversee this combination in 2025 and later. As Robert already said, rigorous documentation and follow-up remain essential, and I think we need to collect more data and make sure that these findings will be confirmed in the future. And it's not yet clear to what extent regulatory agencies will integrate this new piece of information, and also what will be the impact on accessibility, because it's clear that we have been very cautious of the last few years. So the use of FIBA has diminished a lot. It's clear that we, in most centers, we took care not to have our patients have access to FIBA on their own at home. So also in some countries, also FIBA is quite difficult to be still available. So how will this impact on the future availability of the drug, and also the trust that the community will have this combination in the future? So there is still some uncertainty here. Next. Well, some takeaways rapidly. Well, good news, APCC can be reconsidered, and clearly there is a real need here for some patients, because clearly 7A cannot alone provide hemostasis in all these patients. It's very likely that although these data are enthusiastic and promising, 7A probably remains the first option. We need to avoid APCC and 7A. And also, I didn't say this, but we have very little information on the co-administration of tranexamic acid, so we still need to be quite cautious. Close monitoring, safety documentation remains strictly required, as well as ongoing education and collaboration. But I think this is clearly the purpose of this kind of webinar organized by RPTH. So that's it for me, and happy to discuss this and take questions.
Yeah, that was great. That was great, Dr. Hermans.
Thank you, Cedric. Thank you, Robert. It's great overview of the paper and the commentary. And I'd just like to give you both a sort of a comment from me as editor and also as a hemophilia treater, and why we thought this was an important paper for us to publish. Because as you have seen, the majority of the data comes from the Haven studies, and the real world data is relatively small. As an individual hemophilia treater anywhere in the world, you can see the Haven data because it's just 3 papers and you know that information. However, to be able to capture all of the other information from the smaller cases is much more difficult. Yes, there are limitations in how you capture them, but having a single paper to capture all of these, we felt it was useful for clinicians everywhere. And it's important because it's impossible for clinicians to know all the evidence on all the products all the time.
Yes.
So,
And I think we forget that not everybody has access to all the different journals in which those case series were published.
Yeah.
But it's nice to be able to summarize it. Yeah.
So we've got plenty of questions, I'm glad to say. So let's start with this. The one that came first was an interesting one. And it says it's from an anonymous sender. And it says for the 2 of the 3 TMA cases, there was sequential combination. Oh, it's on the screen as well.
That's fancy, yeah. Nice.
Of both 7A and APCC that contributed to their TMAs. And why has APCC been implicated as the drug that was causing this rather than the other half of the drug that was the 7A?
Yeah, I mean, that's a great question. I think, as not expected, not surprisingly, most of these situations, 7A was attempted first. And when there was a failure, FIBA was added, at least the later on when the restrictions were there. So I think it probably stems from the fact that we certainly have seen thrombotic events from emicizumab and 7A. Those have been well documented. I think Flora Pavandi had a nice paper that looked at the eurovigilance data and demonstrated that risk. And we all know that there is an inherent risk. But what we haven't seen TMA events when it's only emicizumab and 7A. And I can tell you, when we look at these reports, we're always at the mercy of what people provide the data for. And so we don't know sometimes if they're on Lysteta. We don't know if they got Amicar. Sometimes we didn't even know what dose per kilo. They just listed, they got 5,000 units. I don't know what that means. Like, how much did the guy weigh? And so I think that's where we're always limited on this. But it's mostly the blame was placed on APCCs because of that. And the potential mechanism of action that Cedric outlined. That's a great question.
I don't know if you have anything additional to say, Cedric, otherwise we'll carry on.
Well, if you look at the mode of action of, ME and APCC, it's clear that combining these 2 agents is clearly associated with a risk. This is obvious. And honestly, I would certainly blame APCC before 7A if there is a combination, just based on the mode of action.
Thank you. We'll take the next question, and I'm not sure whether it's a typing error here, but it's the one from Abdul Manan. And he asks, so we can use FIBA less than 10 units per kilo in patients on emicizumab, 1 dose at least. I suspect he may have meant less than 100 units per kilo as a single dose.
That's probably, there you go. There you go. No, I think if you're talking individual dose, I mean, the way that I can just tell you the way that we've been managing these patients, we tend to give 20 to 30 units per kilo. We usually don't give more than 2 doses a day unless it's some dire situation. And so we try to stay far away from that limit. And we have not seen any issues in the multiple times that we've done it at our institution. We've had additional cases, even have a patient that we're going to be doing that this week. And so there have been cases post this publication in which we've used FIBA successfully without any concern. We don't even check serial labs anymore. We used to do that just for documentation, just so we can come back later and say the patient did fine, particularly if they're admitted. So
would you ever use a single dose of 100?
I've never given a dose more than 50 personally.
Okay. Cedric?
Yeah, and maybe also in terms of convenience, for the patient, that also, it's very likely the patient gets prolonged protection, with APCC plus. So we need to think about that. Could replace multiple injections of 7A. So that is important, especially, sometimes in busy hospitals where you don't have full control on what's happening, could have an advantage. I don't know. I'm not sure that has been formally studied, but there are some practical advantages, and maybe also pharmacoeconomically could result in some savings. So that needs to be considered too.
I mean, if you think about, all the cost comparisons have been the full dosing, which was typically around 60 units per kilo per dose.
Yeah.
And there's at least in the United States, there's a dramatic difference in cost if you're using for example, 20 to 30 units per kilo, 1 or 2 doses, that's certainly less expensive.
Yeah, and maybe another comment is, depending on the type of bleed, because I don't know if we have this data, maybe some kind of bleed may be better controlled with this combination, APCC plus FEBA versus 7A. So maybe, the future, that's why, as you said, we need to collect more data, because it could be helpful in the future.
I'm convinced if we knew all of this, that we could have come up with a low dose APCC strategy, and we would never have seen any of these events. But obviously, this is the way it doesn't.
Yeah, the information I got, I don't know if some Japanese colleagues are watching this, but I had the info that in Japan they never gave FEBA to someone on EMI, never, because they anticipated that this combination. There's so much insight in the mode of action, so they never did this. I don't know if this is correct, but this is information I heard.
Yeah, I mean, it certainly makes sense. You're providing factor 9, just like you mentioned, which the synergistic effect, and then you're getting improvement. It seems like it would be the most efficient way to achieve bleed control, because you're providing emicizumab with the substrate in which you can improve thrombin generation versus a separate, independent. But it is what it is where we are.
In a follow-up to the question that was asked about the 100 units, it's a strange one. To me, it seems odd that 100 is just a round number. And was that really what was shown in the papers? Could it be that it's 90 or 85 or 105? Yeah.
It's a nice number to remember. It's easy for us to remember too.
Same as the 50.
Yes.
51 dose, 100 cumulative.
Yeah.
I think it is possibly because at this stage, it's easy to remember rather than more than that.
It's like when somebody reevaluated the prevalence of hemophilia B, it wasn't the exact 1 in 25,000. And I was like, I cannot remember. I don't even remember the number, but it was a number that I'm never going to remember. So, yes.
And if I may follow that to Robert, you presented some data, but it's very small data about the so-called rebalancing agents that have been approved in the last year.
Yeah.
Do you think the dosing will be similar to what is suggested for EMI and FEBA for those agents?
Yeah, I mean, it should be. I remember when we looked at this data, some of this is very difficult to get a hold of. But for example, on the Explorer 7 series, in which they use concizumab, the median dose was 50 units per kilo. I personally probably wouldn't give that dose. And there were patients that had gotten 80 units per kilo. But again, they got typically one infusion, and that was fine. And so obviously, we have to be careful. It's a limited experience in the study. To be honest, I'm surprised that they were allowed to give that product, but it wasn't provided by the company. So, the PI could do whatever they wanted. But I probably would not give such a high dose if a patient was on TFPI drug for certain agents based on the mechanism of action and the probably slightly inherently higher risk of thrombosis. So,
do you have a comment on that, Cedric?
No.
Okay. The next question came just before your slide on that showed that the APCC contained factor 9, and the question is, what is the cause of TMA following APCC? I don't know if you feel you've dealt with that already.
Yeah, Cedric, I don't know if you felt like you answered that, or if you want to add any more.
Well, I'm not sure we know exactly why. I haven't, a lot of speculation, a lot of hypotheses, but honestly, I'm not aware of a very solid explanation.
Yeah. I mean, we know that it doesn't happen with factor 8 products. And so that I think that was a lot of the premise of the 9 being the driver. So, yeah. Okay,
we'll go to the next question. It's rather long. But I think it's about how do you monitor, and how it says regarding the treatment of breakthrough bleeds using a bypassing agent in a patient on emicizumab, how is recovery determined? And recovery meaning, I think, in terms of the bleed, is it purely patient reported, or are there any lab specific parameters as well?
Yeah.
I'm aware emicizumab could have an influence on human-specific reagents.
Yeah, I mean, for us, we just do the old-fashioned way. We look for clinical improvement, reduction of pain, decreased swelling. So, for example, the patient that had an extracranial hemorrhage was a child that jumped off of a table and had gotten a couple of doses of 7A. And this is always the classic scenario. It was a Friday afternoon phone call, wasn't even our institution, and they wanted advice. And I had mentioned APCCs, and I said, just put my name down. I know it's going to be fine. But what they did is when they did an ultrasound, they started to see coagulation of that liquid. I mean, when you do an ultrasound, you see liquid. They saw coagulation products, and there was a significant improvement 24 hours later, and they discharged the patient. So for us, we just look for clinical improvement. We just look. We take a picture and compare it to the day before, and we measure it. I'm sure you guys do the same, where you might have a nurse measure the size.
Any comments, Cedric?
Yeah, well, yeah, clinical ultrasound, if this is a joint bleed, or and if you have someone who can do this. Blood test, all these complex tests, thrombin generation and so on. I think you really need a very good experience with this and be able to interpret the data. So honestly, it would be nice. I think that in the future that could be the way to go, but for the moment, we can certainly not recommend performing this test routinely. It's impossible. Yeah. We don't have the expertise. We don't have the resources.
So hard to do in real time. Yeah,
I think so too. Yeah.
So do you think thrombin generation has a role here other than in research settings?
I personally use it after to verify what I did was the dose was reasonable for historical purposes. But then also we had trouble with a couple of cases in which we got the samples weren't very good, I guess. Maybe they didn't get processed. If you've ever done thrombin generation, it is very finicky. You have to process it very quickly, and you have to have it ready to go with the sample. So it is, it's easier said than done. I've done it before, and I was not a big fan of it. So,
well, I can comment on that. We've done a lot of work on this, and my view is that this is at this stage is a research setting rather than for use in management, other than in very specific centers who are enthusiastic about this. Okay, we'll move on.
For the future, I think they will probably be important if you think about all the non-replacement therapies and the new mimetics and so on. But I agree, major efforts are needed to standardize them and make them interpretable and usable at an individual level. But I think efforts are needed here. Yeah. We need to, I think this is needed.
Okay. Fortunately, we've got one question left, which we will ask. All the other questions have already been answered. And fortunately, the questioners have told us their questions have been answered. Thank you for that.
Yeah.
So the last question comes from Prasad Matthew. Hi, Prasad. And the question is, what are your thoughts about using 7A and FIBA in sequence in non-responders following the half-life of these products?
I can tell you, so I know, I remember Dr. Ragney had published a paper looking at sort of pre-emicizumab era using sequential dosing regimen. There was a very complicated system of doing this to try to, for safety purposes. I personally would not be that interested. I would try to choose one over the other. And then if there's a failure, then consider dosing. I would be very careful at giving large dose 7A, so the large dose epticog alpha beta, and then immediately give FIBA, more than 8 hours later. So that's where I would be very careful. So.
Yeah, although that would depend on the clinical setting. If this is a life-threatening bleed, and
sure.
Well, in that kind of situation, but you need to make sure that there is no overlap and take into account the respective kinetics of these agents. Why not? But in very limited settings.
Yeah.
Yeah, and someone in the comments has just put that the sequential dosing was responsible for some of the TMAs, which confirms what
it's a good point. It's a good point.
Yeah. Well, we're at the top of the hour. We've had an excellent seminar with lots of discussion.
Yeah.
Thank you, Robert. Thank you, Cedric, for your invaluable comments. It has been great pleasure to listen to you on these topics. And we hope our viewers that are following us will read the full paper if they have not done so already. And
the commentary.
And the commentary. Yeah.
Thank you.
Of course. You have to read them together.
Yes.
Both of them have got
Required.
their own valuable information and how you should interpret the paper.
And freely accessible.
Yes.
And both freely accessible as it's published in RPTH.
Yeah.
So finally, thank you to Takeda Pharmaceuticals for supporting this webinar with an educational grant. And thank you to everybody for joining us today, and keep an eye out for the next RPTH Research Recap. Thank you.
Thank you. Bye-bye.
Thanks.